Madam, we are live now. Shall we start?
Yes.
Good evening, doctors. I, Shuman, on behalf of Shield Healthcare, welcoming you all in another interesting session on microbiome and ART. And our guest speaker is Dr. Sinha, madam, and it's me honor to introduce madam. Madam did her MBBS, MS Obstetrics and Gynecology, and DNB. She was the specialty medical officer in NWM Hospital, Mumbai. She did her fellowship in reproductive medicine and ACRM certified in IVF and ICSI, Cleveland, USA, FMAS. She is a fertility specialist and gyne laparoscopic surgeon, and presently the director of Women's Clinic in Ranchi, Jharkhand. So, with this short introduction, I request Madam to take over the session. And meanwhile, I request all the participants for your active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you, Madam, and over to you, ma'am.
Yeah. Good evening, everyone. Thank you for sparing this time of their day when everyone has have done with their day and they want to rest. But yes, we are with a very interesting topic, microbiome and ART, that is assisted reproductive technique. Somehow we have always focused on other aspects of getting better result in our ART assisted reproductive technique treatments, but now with as we are getting exploring more, we have now through various studies we have now the importance of maintenance of microbiome is very important in getting good result in our ART practice. So here we start. The vaginal microbiota plays a pivotal role in maintaining the physiological homeostasis of the environment and protects from the colonization by opportunistic pathogens. A healthy vaginal ecosystem is characterized by predominance of lactobacillus species. These are mainly Lactobacillus crispatus, Lactobacillus iners, Lactobacillus gasseri, and Lactobacillus jenseni. And these lactobacillus species mainly contribute and actively contribute to the vaginal pH, that is less than 4.5, through a lactic acid production. From studies, we have got to know that a healthy vaginal microbiota is different in different population. So in a non-pregnant woman, lactobacillus is the predominant microorganism, but in commercial sex worker, it is mostly replaced by Gardnerella, that is bacterial vaginosis, and again in pregnant women, it is lactobacillus. Depending on the age of a female, the normal vaginal flora has different composition. So when a girl is born up to 6 weeks, because of the effect of the estrogen of the mother, the lactobacilli is there in our vaginal ecosystem, and this lead to acidic pH. Other microorganisms like Streptococcus epidermidis, Streptococci, Enterococci, and Enterobacteriaceae are there. In prepubertal age, there is absence of estrogen, so there is no lactobacillus, and so the pH is neutral. Other microorganisms are there. There is and their presence of Gardnerella, Mycoplasma, and Uroplasma is also there. As she reaches puberty, with increase in estrogen in her vaginal ecosystem, again there is the predominance of lactobacilli along with Gardnerella, Mycoplasma, Uroplasma, and all Streptococci, Enterococci. The pH again becomes acidic. Then in similar manner, in menopause, as there is deficiency of estrogen, so there is paucity or absence of lactobacilli, leading to a neutral pH in vagina. So what's the role of vaginal lactobacilli? These, because of increased estrogen, these lead to increased glycogen deposition in the vaginal cells. Means this is the organelle inside the cell of vaginal epithelium, and these glycogens are degraded by alpha amylase enzyme to maltose, maltotriose, and alpha dextrin, and the lactobacillus then act and convert it into lactic acid, and acid being acidic, it decreases the pH. And now altered microbiota and infertility. Evidence from several studies shows that there is different vaginal micro organism composition in infertile women as compared to healthy and fertile women. An abnormal vaginal microbiota has been associated with a poor reproductive outcome in patients undergoing in vitro fertilization, as well as with early spontaneous abortion in patient undergoing in vitro fertilization treatment. So it's not just important for conceiving, it's also very important for maintaining the pregnancy after treatment. So what's the lactobacillus effect? The effect of the presence of lactobacillus within a local microbial community could be explained by its antimicrobial characteristics, such as the ability to produce lactic acid. The main property of lactic acid is to lower the pH of the local environment. Because of its acidic nature, it provides protection against the invading pathogens. Lactic acid also prevents vertical transmission by affecting the integrity of the cervical plug. Lactobacilli also produce bacteriocins, which have a potential to inhibit the bacterial growth and physically prevent colonization of other bacteria from preventing them from binding to the epithelial surface. So there are different lactobacillus species and they have different immunicity. Lactobacillus crispatus plays a role in protection against pathogen. The presence of lactobacillus inners can cause altered gene expression, including defense against bacteriophages, and is associated with the presence of bacterial vaginosis. What is vaginal infection? A woman's vagina makes discharge that's usually clear or slightly cloudy. In part, it's how the vagina cleans itself. It has the following signs and symptoms like vaginal discharge, changes color, is heavier or smells different, can cause itching, burning, swelling or soreness around or outside vagina, and difficulty in micturition. Bacterial vaginitis can spread from the vagina up to the uterus and fallopian tubes. This kind of infection is called pelvic inflammatory disease and can, if left untreated, cause the damage to the tubes, and this can prevent sperm from reaching the egg and cause infertility. Then recurrent vaginal yeast infection can cause the internal vaginal flora to become unbalanced, which may make it hard for the sperm to reach the uterus. And they are also associated with the altered vaginal microbiota, can lead to urogenital problems like vulvovaginal candidiasis, bacterial vaginosis, urinary tract infection, and pelvic inflammatory disease. Vaginitis, that is inflammation of vagina, it is the most common gynecological condition encountered in outpatient clinics, defined as the spectrum of conditions that cause vulvovaginal symptoms such as itching, burning, irritation, and abnormal discharge. And the most common causes are bacterial vaginosis that contributes to up to 40 to 45%, vulvovaginal candidiasis 20 to 25%, and trichomoniasis 15 to 20%. Bacterial vaginosis is the most common cause of vaginal irritation, itching, and discharge, and is sometimes referred to as Gardnerella. It represents a complex change in vaginal flora. There is overgrowth of other bacterial flora, and there is decrease in lactobacilli. 16% of women may have bacterial vaginosis, many with no symptoms. Symptoms: fishy, musty odor often after intercourse, pain, itching, burning, profuse white or gray discharge. Increase in Gardnerella vaginalis, Mycoplasma hominis, and anaerobic Gardnerella rods. Exact mechanism by which changes take place is unclear. And this has to be differentiated from physiological discharge, because this is the way by which vagina clears itself. So there are conditions in which the physiological discharge increases, like there is increased production of mucus from the cervix in mid-cycle under the effect of progesterone. It is important to differentiate normal physiological change from true infection. Normal vaginal discharge is white and it can become yellowish on contact with air, consists of desquamated epithelial cells, mucus, bacteria, and fluid, form as transudate from vaginal wall, pregnancy, and combined oral contraceptive pills. Depending on the different ethnicity of women, the lactobacilli species predominantly colonizing them are different. It has been found like in white and Asian women, Lactobacillus crispatus is dominant in 26.2%. Lactobacillus gasseri is dominant in white or Asian women in 6.3%. And same Lactobacillus jansenii is predominant in 5.3% of white or Asian women. They have different properties as well. Lactobacillus crispatus, it has highest lactic acid production, causing pH to be 4, and it is relatively stable vaginal community, more likely transition from to Lactobacillus iners, and less likely transition to BV state. Like lowest prevalence to viral STIs also, and core genome is host adhesion factor and factor for competitive exclusion of Gardnerella vaginalis. So it has the most protective role. Lactobacillus gasseri, it causes lowest lactic acid production, so the pH is 5, and it is relatively stable vaginal community. Lactobacillus jansenii dominated white and Asian women. They have moderate lactic acid production and pH 2 up to pH of 4.7, and we have like no information regarding its community stability. Then Lactobacillus that has a moderate lactic acid production of pH 4.4, and it is isolated from both healthy and BV state. It is dominant species following BV treatment, often isolated from transition type of BMB. Adaptation to vaginalness, CRISPR system, iron, sulfur, gene, cholesterol dependent cytolysine, these are all the metabolic things inside it. And Black Hispanic women have 27% are vaginal microflora is dominated by non-lactobacillus, and these are abundant species maintain low pH of 4 to 5, low Nugent score, healthy or asymptomatic BV state. Overgrowth of facultative strict anaerobic bacteria, they have no to low lactic acid production, so the pH is 5.3, high Nugent score, polymicrobial biofilm of with Gardnerella vaginalis, and they facilitate acquisition of STIs. Vulvovaginal candidiasis. Vulvovaginal candidiasis is usually caused by Candida albicans, but occasionally is caused by other Candida species or yeast. And estimated 75% of women will have at least one episode of vulvovaginal candidiasis, and 40 to 45% will have 2 or more episodes. On the basis of clinical presentation, microbiology, host factors, and response to therapy, vulvovaginal candidiasis can be classified as either uncomplicated or complicated. Approximately 10 to 20% of women will have complicated vulvovaginal candidiasis, suggesting diagnostic and therapeutic consideration. Trichomonas vaginitis. Trichomoniasis is caused by the protozoan Trichomonas vaginalis. Many infected women have symptoms that are characterized by diffuse, malodorous, or yellow-green vaginal discharge with vulval irritation. However, some women have minimal or no symptoms. Note the frothy discharge seen around the cervix. And as it is a flagellated protozoa, and it affects 2 to 3 million American women annually, and it's the third most common vaginitis. Flagellated protozoa infects vagina, urethra, and paraurethral gland, virtually always sexually transmitted. And its clinical feature ranges from asymptomatic infection to severe acute inflammatory disease. Purulent, malodorous, thin, frothy discharge, dysuria, dyspareunia, and pruritus are common. On examination, we can find strawberry cervix, so that is inflamed cervix with yellow spots resembling a strawberry, and there's intense itching and vulval soreness. Treatment for trichomonas is like we have to treat both partners, because always it is sexually transmitted. Both should be screened for other sexually transmitted infection. The treatment is to give 2 gram metronidazole stat or 500 milligram twice a day for 7 days. There's very little role of topical therapy. Treat sexual partners simultaneously. If refractory to treatment, retreat within 7 days course. If fail, again try 2 gram dose daily for 3 to 5 days, and assure compliance with partner or culture. Vaginal microbiota in pregnancy is less rich, less diverse as compared to non-pregnant vagina, with predominance of lactobacillus species. A significant higher stability of vaginal microbiota in early stages of pregnancy, and the same increase with gestational age. The etiology including estrogen increasing the thickness of vaginal mucosa, thereby increasing the glycogen deposition. This glycogen deposition acts as chemotactic agents for microbes, as this is major substrate used by these microbes, which is broken to glucose and then fermented to lactic acid, thereby playing a significant role in lowering of the vaginal pH. So there are many published articles associating like different vaginal microbiome. So one of these is differential composition of vaginal microbiome, but not of seminal microbiome, is associated with successful intrauterine insemination in couple with idiopathic infertility. So it's a prospective observational study. So it has been found that the patient in whom there was lactobacilli was predominance. They have, in cases of unexplained infertility, the IUI success was there, but when it was a Prevotella or other microorganism that was there was no IUI success. This was compared with controls. The vaginal microbiota and its relation to IVF. Altered vaginal microbiota and vaginal vaginosis may be related to poor pregnancy outcome. Therefore, patient undergoing IVF should be screened and eventually treated to enhance the success. Studies confirm that vaginal microbiota rich in lactobacillus species without bacterial vaginosis, either clinical or subclinical, lead to more positive outcomes with ART. And this study, and these are shown by a study by Babu et al. In 2017, Eckhart et al. At 2003, Mangot Bertrand et al. In 2013, and Murray et al. In 2000, as well as with Har et al. In 2016. Cooder et al. Performed a prospective study of reproductive age women undergoing IVF and found that embryo implantation was less successful in women with reduced lactobacillus species in their vaginal microbiota. Vaginal microbiota is important for the health of whole reproductive tract and for prevention of pathological infections. It can be expected that it affects not only pregnancy but also delivery. The vaginal microbiome evolves during pregnancy in relation to gestational age and tends to lose the diversity observed in non-pregnant women. This was found by Freitas et al. In 2017, and Ron et al. In 2019 found that a non-lactobacillus dominant vaginal microbiota and increased bacterial diversity during pregnancy are associated with higher risk of preterm birth. And the endometrial microbiota and its relation with IVF. Moreno and Simon in 2018 found that endometrial dysbiosis can be the cause of implantation failure and lead to infertility. A lactobacillus dominant endometrium is more receptive than an endometrium with high bacterial diversity and a low proportion of lactobacilli. It can be expected that hormones also influence the endometrial microbiota. So, as we all know, the pathophysiology of bacterial vaginosis in female infertility, it increases the concentration of interleukin 1, which is an inflammatory cytokine in the vaginal environment, and trigger the generation of reactive oxygen species, affect the membrane integrity and flexibility, and impair both tail motion and sperm oocyte fusion, and thus disrupts the fertilization and implantation. Negative effect of ART procedure. Contamination is possible from vaginal cervical microorganisms by needle puncture of the vagina during OPU, and microorganisms that enter the endometrium from cervix during embryo transfer could damage the developing embryo and thus prevent pregnancy. So what's the treatment available with us? So we have to make the environment lactobacillus dominant, and IVF outcome, as we know, is depends on the vaginal microbiome. So there, if lactobacillus species is less, there is a lower implantation rate, increased number of miscarriages, decreased number of term pregnancies, and reduction in pregnancy rate. So treatment guideline for bacterial vaginosis is metronidazole 500 milligram twice a day for 7 days, or metronidazole gel 0.75%, one applicator intravaginally once a day for 5 days, clindamycin 2% cream. These are guidelines by CDC, America. One applicator 5 gram intravaginally at bedtime for 7 days, or alternative treatment are tinidazole 2 gram orally once a day for 2 days, or tinidazole 1 gram orally once a day for 5 days, clindamycin 300 milligram orally twice a day for 7 days, clindamycin ovules 100 milligram intravaginally at bedtime for 3 days. Recommended regimen during pregnancy. Recommended regimen is metronidazole 2 gram post meal once, or tinidazole 2 gram post meal start once, or in 24 hour or to 72 hour. Alternative regimens are metronidazole 500 milligram BID for 7 days, 7 days. And metronidazole allergy is rare. Tinidazole is longer acting. It is now generic and cost competitive. And data from studies regarding use of tinidazole in pregnancy are limited in human subjects, so we prefer metronidazole in pregnancy. Vaginal probiotic, rational to develop because of the clear hypothesis about the role of lactobacilli and clearly established protective role of lactobacilli. Lactobacilli are predominant in vagina. Application can be topical, reaching a high inocular, no organoleptic consideration, easy to perform clinical trials, easy sampling, and easy re-isolation of probiotic lactobacilli after application already available. Study on cervicovaginal microbiome. So as we say, Coider found that microbiome profiling enables stratification of pregnancy chance prior to the start of an IVF or IVF-ICSI treatment. Liu in 2019, he concluded that an abnormal vaginal microbiome is associated with less successful early pregnancy development after IVF treatment. Brown in 2019 concluded that the vaginal microbiome differ greatly between women and fluctuates. The abundance of various bacterial species in the vagina greatly impacts a woman's reproductive health and pregnancy outcome. Skew in 2019 concluded that the interaction of vaginal microbiota and intrauterine adhesion greatly influence the vaginal diversity. Vaginal lactobacillus population is associated with recovery rate and recurrence rate of intrauterine adhesions. And now we will see few studies on endometrial microbiota. So by Garcia and Grau in 2019. So these are all recent studies. These are recent studies emphasizing the role of microbiota in the success of ART treatment. And Gracia Grau found that endometrial colonization of persistent Gardnerella vaginalis could be related to the reproductive failure. Kyono in 2019 found that non-bacillus dominated microbiota present in the endometrium of Japanese infertile women. Hashimoto also found that the endometrial bacterial profiles of pregnant and non-pregnant were comparable. Winters and Kiyata, they found that endometrial fluid and vaginal microbiota have different profile. The endometrial fluid microbiota shows significant variation in community composition between the RIF group and the control group. Burkholderia species were only detected in the endometrial fluid of recurrent implantation failure. And there are studies present on fallopian tube as well. Pelger found that the fallopian tube harbor distinct microbial community profile. Pelger in 2018 concluded that electron microscopy reveals observable microbial cells in fallopian tube sample as well. Lee took vaginal swab and from cervical swab studies that higher viral diversity is associated with prophylactic antibiotic exposure in subfertile women undergoing IVF. Miles found that higher vaginal viral diversity is associated with preterm birth. Changes in vaginal virome diversity appear simple to changes in the vaginal bacterial microbiome during pregnancy. Chain in 2017 concluded that total RNA profiling will advance understanding of the interplay of pathogen, host, and microbiota during natural infection and may reveal novel outcome relevant biomarkers. T. Har and J. S. Jensen in their studies of abnormal vaginal microbiota associated with poor reproductive outcome, and this was a prospective study in IVF patient. The findings were that abnormal vaginal microbiota may negatively affect the clinical pregnancy rate in IVF patients. If a negative correlation between abnormal vaginal microbiota and the clinical pregnancy rate is corroborated, patient could be screened and subsequently treated for abnormal vaginal microbiota prior to fertility treatment. Immaculado, Monero, and Carlos Simons, in their study of relevance of assessing the uterine microbiota in fertility, found that technical advances in massive parallel sequencing have allowed the characterization of whole reproductive tract microbiome in all the compartments beyond the vagina. The microbiota in uterine cavity seem to be a continuum from the microbiota in the vagina, and several work have reported significant differences between vaginal and endometrial microbiota, highlighting the relevance of assessing the upper genital tract microbiota to better understand the potential roles of bacteria in the physiological and pathological process taking place in the uterine cavity, including embryo implantation, pregnancy maintenance, and other gynecological diseases. However, the study of the endometrial microbiota, as with other low biomass microbiota, presents important hurdles because due to the small amount of starting material, they are easily contaminated by exogenous bacterial DNA. For this reason, careful and appropriate investigation of the endometrial microbiota is of outstanding importance to detect uterine dysbiosis that may impact the reproductive function. And this has been published in Fertility Sterility 2018 by ASR. And evidence that endometrial implantation success or failure, the result was that the presence of non-lactobacillus dominated microbiota in a receptive endometrium was associated with significant decrease in implantation, 60.7% versus 23.1%. Pregnancy 70.6% versus 33.3%, ongoing pregnancy 58.8% versus 13.3%, and live births 58.8% versus 6.7%. So as a conclusion, our results demonstrate that the existence of an endometrial microbiota that is highly stable during the acquisition of endometrial receptivity. However, pathological modification of its profile is associated with poor reproductive outcome for in vitro fertilization patients. This finding adds a novel microbiological dimension to the reproductive process. As this study we have discussed earlier, so treating bacterial vaginosis also increases the pregnancy rate, just doubles it. So gist is that although it is a very trivial topic of microbiome, nobody is much bothered about it, but surely it has a major role to play in the success of our ART treatment. Especially it has impact on the fertilization, implantation, and continuation of pregnancy and the continuation of pregnancy. Thank you everyone for giving a patient hearing.
Thank you very much, ma'am, for this nice presentation. Just give me 1 minute time to collect the question from the dashboard, ma'am.
Sure.
Madam, I took same question. That is, can these probiotics can be given after the first trimester of pregnancy? What is your thought on that?
Yes, probiotics can be given from after first trimester of pregnancy. These are not backed by good randomized controlled trials, but in few patients of ART where we are not getting success, we are even including it in the treatment after embryo transfers also. So yes, it can safely be given after first trimester of pregnancy.
Thank you very much, ma'am. Ma'am, another question: does this probiotics be given prior to ART, or if there is any ART failure during the investigation, if something found, then only you give that probiotics for the patient?
See, everything depends, because we don't have a good investigation to know what is the predominance of lactobacillus species or what is the exact composition of the vaginal ecosystem. So any patient who are symptomatic, like any kind of signs of vaginitis is there, or there are proven cases of recurrent implantation failure or previous preterm labor, yes, we can give probiotic. As I've already said, we don't have good studies to back these things, but yes, on experimental basis, we can give.
Thank you very much, ma'am. And what is your opinion on this vaginal ecosystem? I mean to say that only the lactobacillus strain is enough to maintain the ecosystem, or is there any other strain that must be given along with this, like bifidobacterium or something? that can be given along with this lactobacillus to maintain the proper microbiota?
Now there are different kinds of probiotic that are available. Few probiotic, they have exact what is there in the ecosystem, like lactobacillus crispatus, uh, geneticus and generi. These exact they have the composition of these lactobacillus, but few other have lactobacillus bifidus. So but yes, there is no study to prove that whether giving this will help or not, because from the study we know that those that are already present in lactobacillus, so we know for sure that they are going to help it, but we don't know the effect of other lactobacillus like bifidus, how they are going to help, or they are just placebo. So we don't know.
Thank you. Thank you. Thank you very much, madam. I could not find any other question right now. So thank you very much once again for your valuable time and for such a nice discussion and a very important discussion on this microbiome and the microbial ecosystem of this and its implication on this ART. So thank you very much once again. And in future also, we will look forward for some valuable session in some interesting topic also with you, ma'am. So thank you very much and have a good day.